All right, welcome everyone. My name is Ben Marlin. I'm a faculty member in computer science at the University of Massachusetts Amherst and associate director for the Massachusetts AI and Technology Center for Connected Care and Aging and Alzheimer's Disease, or MASS AITC. I'll be hosting today's webinar with Professor Inan. For those who are joining for the first time, MASS AITC is an NIA-funded center focused on technologies for supporting aging and ADRD care in the at-home setting. Today's webinar is the third in a series of technology-focused talks hosted by MASS AITC. The first talk in this series was given by Dr. Ed Ramos from Care Evolution and focused on digital and remote study designs. The second talk was given by Professor Pedja Klasna from the University of Michigan and focused on user-centered design principles. Both of those talks are available on YouTube, and we'll put links into the chat for those of you who missed them. The next talk in this series will be given by Professor Santosh Kumar, a pioneer in the field of mobile health, and is coming up in 1 month on Tuesday, September 26th at 3 p.m. Eastern. That talk will focus on the development of mobile health digital biomarkers. We'll get a registration link in the chat for those of you who are interested in attending. Today, it's my pleasure to welcome Professor Omer Inan to the webinar series. Professor Inan is the Linda J. and Mark C. Smith Chair in Bioscience and Bioengineering in the School of Electrical and Computer Engineering at Georgia Tech. His research focuses on non-invasive physiological sensing and modulation for human health and performance. He's the author of more than 300 technical articles on these topics and has also been issued 12 patents. Among many other accolades, Professor Inan is a fellow of the American Institute for Medical and Biological Engineering, a fellow of the American College of Cardiology, and an IEEE Engineering in Medicine and Biology Society Distinguished Lecturer. In today's talk, Professor Inan will describe his work on developing vibration and acoustic sensing and analytic approaches with applications to cuffless blood pressure monitoring, heart failure monitoring, and monitoring of joint disorders. This talk will be of great interest to the MASS AITC community due to the combination of novel sensing and analytic approaches coupled with the potential to lower costs and achieve improved outcomes for older adults and others across a range of health conditions. In terms of logistics, please note that this talk is being recorded. We have reserved time for questions and discussion at the end of the talk. I'll ask that folks put any questions that come up during the talk into the chat, and we'll circle back to them following the presentation. And with that, I'll turn the floor over to Professor Inan. Thank you very much and welcome.
Maybe I'll try that again without muting myself. So thank you very much. Thanks for having me give this talk, and I hope at some point I can also visit in person and see you guys and catch up again. But I really appreciate the opportunity to be here. Of course, it's always a bit strange giving this talk where you can't see anybody's faces or reactions. So I'll tell you what, we'll change the format slightly. And if you do have a question, you can jump in every now and then. But I do know that we want to make sure to try to keep things to about half an hour for my talk. So I guess there can't be that many questions. And I guess also that means I should probably move on from the title slide. So let me go ahead and move forward here. I have a few disclosures. So we have some startups that have come out of my lab. The stuff that I'm going to talk about today is definitely related to those. Of course, those startups are licensing IP from Georgia Tech that was developed by our lab to be able to sort of get it out there in the real world and try to make something of it. So I'm very involved in those, and I have to kind of disclose that up front. So, you know, what gets me sort of excited is technology that can help to better deliver care, and really whether that's to allow doctors to have better access to information that comes from patients that can help them to make more informed decisions, whether it's information that patients can learn about their own body that can help them to make better behaviors and decisions in their life, or some combination. You know, this area is really budding and exciting, and there's so much cool stuff going on. You have to have something where you sort of draw the line of what is your sort of focal point of interest. And for me, maybe because of my industry background, which was really focused on acoustics and the measurement of really high performance audio in some challenging environments, I think that what I've sort of gravitated towards and what's been a major focus in our lab has been the study of the sounds and vibrations of the body and how those can be used to assess human health and even human performance. And so every day as we're sort of performing our normal processes of living, there's sounds and vibrations being generated by our body. We're aware of a lot of these, of course. You probably think about, for example, maybe you think about your heart as sort of performing some vibrations. When you touch your chest, you can actually feel your heart move. If you touch the right sort of spots on your chest. Your joints are actually making sounds depending on your age. Maybe the people listening to this talk don't really hear their joints make sounds, but as you get older, you hear actually your joints creaking and cricking as well. And so there's a lot of sounds and vibrations that sort of our body is producing continuously. And so in this talk, really, I'm going to focus on two areas. I'm going to try to keep this to about half an hour. If it goes longer, then I'm going to have to start moving faster, I guess, at some point. But first area I'm going to focus on is the heart. And then from there, we'll talk about some of the stuff we've done on joint health. So the heart, of course, sitting within your chest. Every time your heart beats, it produces some sounds. Those sounds are associated with the closures of the valves. The valves kind of prevent blood from flowing in the direction it's not supposed to go. At the same time, your heart is imparting some very big forces onto blood to be able to move it all through the body. When your left ventricle is ejecting blood into the aorta, that blood is then traveling everywhere in your body except the lungs. Everywhere that requires oxygen, everywhere that requires nutrients, and then requires the blood to take away waste, the heart is delivering the blood there. And so that force that's imparted actually is fairly violent. And every time that force is imparted, there's vibrations that are induced that can be sensed on your chest wall. What we're maybe more familiar with is probably not what's on the slide, but the concept of what's on the slide, which is that every time your heart beats, there's actually an electrical activity associated with that leads to a signal called the electrocardiogram. And the original instruments that were used to measure electrocardiography, this one by a gentleman named Einthoven, were these giant sort of contraptions where the person had to put their hands and feet into buckets of salt water. And then from there, this giant instrument would measure their heartbeat. What's maybe less well known, maybe that's already not so well known, but what's less well known is that while the concept of measuring electrical aspects of cardiac health and performance dates back about 100 years, the concept of measuring the sounds associated with the heart actually dates back 250 years plus to this gentleman named Laennec. I totally pronounced it wrong because I don't know French, but something along those lines, who had a device that he created that would allow him to actually listen to the heart sounds. And then he would use percussion in the measurement of these sounds to determine some characteristics of the patient's health. So what our group has developed that we're now commercializing through this company, CardioSense, but on the academic side, what we've developed is this wearable chest patch that allows for the concurrent measurement of the electrical and mechanical aspects of cardiovascular health in the same packaged unit that sits on the chest with 2 ECG electrodes as the adhesive material. So with this patch, we're able to measure the electrocardiogram continuously. We're also able to measure the mechanical aspects of heart function, the signal called the seismocardiogram. And we're able to measure optical blood volume pulse signatures of both red, green, and infrared wavelengths in 2 different locations. So this multimodal chest patch that we created for sensing these various cardiovascular signals was something that was developed through NIH funding, focused first on heart failure monitoring. And since we've actually used this for many other applications. We've done, this is sort of a compilation of the different studies that we've done with this device, not exhaustive, but we've done a lot of work on trying to relate the things that we measure with this patch to better understood clinical signals, such as filling pressures like pulmonary capillary wedge pressure, cardiac output, and other sorts of signatures, and demonstrated that there's value not only in healthy participants, but also in patients with heart failure and other kind of populations. So the specific problem we're trying to address with this device is the early detection of hemodynamic congestion in patients with heart failure. This was the original goal. This is what caused us to develop the technology in the first place. And so It's better understood now because of implantable devices that when a patient with heart failure, which is a condition experienced by about 5 to 7 million Americans currently, and is the #1 Medicare cost every year at about $30 billion, maybe more now, sorry, maybe more like $35–40 billion per year. And in the aging population, by the way, is very prevalent and is, again, one of the leading causes of mortality and also something that really affects quality of life in older populations. So in heart failure, unfortunately, what happens is because the heart is unable to produce enough blood, move enough blood to the regions that need it in the body, it starts to fail. And what ends up happening is there's a cascade of events where the body is trying to retain fluid and adjust its state to be able to help the heart, but actually the changes that it makes end up hurting the heart. And so there's a slow decompensation, is what it's called, process that occurs over the course of tens of days. And at the end of this process, basically the person is congested. They have fluid in the lungs, they have fluid in the ankles, they have a hard time breathing, they have a hard time just performing any sort of daily living activities at all, and they have to be hospitalized. It's an emergency event. During this hospitalization, what ends up happening is there's sort of this treatment that occurs over 2 weeks, 3 weeks. Sometimes it might be slightly shorter, sometimes it could be longer. And then they go home and the same process kind of repeats. So what's been detected with implantable devices that actually measure directly what's called filling pressures is that those pressures change 10, 20, even 30 days before this hospitalization event. And so they represent the earliest possible signs of this decompensation that could potentially be predicted. So our concept has been that, implantables are available for about, tens of thousands of heart failure patients among this 5 to 7 million that are suffering from the disorder. And if you think about the people that might be at risk of developing heart failure, you of course think about even a greater population. But our concept has been that if you provide this wearable device that can possibly measure these same filling pressures that are currently only measured with an implantable, and if this device could then be used within the sort of standard of care with either the caregiver or clinician or service providers, third-party service providers to help manage the person's symptoms and specifically their fluid status at home, that you might be able to keep them out of the hospital longer. So in a lot of the work that we do, what we have to do is we have to partner with clinicians to be able to do studies that allow us to have gold standard measurements that we compare against in the population that we care about. So we recently published a paper in IEEE Transactions on Biomedical Engineering where we demonstrated that with our chest patch, compared to the gold standard, which is actually right heart catheterization, so the direct insertion of a catheter into the pulmonary artery, pulmonary capillary wedge, that we were able to detect changes in these filling pressures that occurred with a vasodilator infusion. And so the concept was, if you send patients home with these devices, if their pressures start to change because of fluid retention or other factors, can you detect them with our wearable? And what we found was actually the timings and amplitudes and other features of this wearable, especially in the lateral axis of vibration, which was sort of a new finding, represented the changes in filling status that were measured with the catheter. And so we were able to show with this sort of leave one subject out validation approach that we could, actually we moved to leave a few subjects out, fully held out validation set approach, that we were able to get a high quality regression and estimation of these filling pressure changes in a total of 20 subjects with heart failure that had right heart cath. And essentially the process, I don't have time to go into much of the details here, but essentially the process was using the signals from the patch and being able to detect the changes in the seismocardiogram, this wearable vibration signal in particular, to be able to identify these changes in filling pressures. So, the sort of filling characteristics of the heart are interesting from the standpoint of heart failure because of the fact that somebody with heart failure has impaired cardiac output or impaired ventricular performance, which is what's shown on this y-axis of this plot. So the purple curve here, specifically someone with heart failure. The orange curve is somebody with normal cardiac sort of health. And basically, this is a plot known as the Starling curve, where normally if you increase the person's filling status, then you will actually increase their ventricular performance. In heart failure and in fatal myocardium depression, basically very severe forms of heart failure, you can actually increase the filling characteristics, but not see an increase in ventricular performance. What we were interested in is if you can detect volume overload in patients with heart failure, can we also detect the reduced volume that occurs in persons with trauma, and specifically people who are bleeding out? So this could be combat casualties, let's say, who are losing their volume. And so we got interested in this problem of hypovolemia. And in hypovolemia, I'm not going to get into too many details here, but essentially there's absolute and relative hypovolemia, where a person can have essentially either reduced overall volume of blood or an increased capacitance that they're trying to fill blood with. And in this situation, basically the heart is starved of what it needs to be able to sort of perform highly. So together with Professor Jinho Han of University of Maryland, we've been working on a project where the concept is to have the wearable device on the chest, providing volume status information that could then be used with closed loop control algorithms to be able to provide emergency care decisions, which can include fluid resuscitation, but also can involve other sorts of interventions as well. So for this one, very little was understood in the literature on how these chest wall vibration signals relate to underlying volume status in the context of hemorrhage. And so we had to actually perform a large animal study to better understand the scientific details of what's going on. And so in the animal study, we were able to combine all of the implantable measurements of pressure together with the non-invasive measurements with our device, and we're able to start forming some relationships there. And specifically, we demonstrated in some work that we published in Science Advances that we could actually see a monotonic change in our predicted volume status that was proportional to the change in actual volume status as measured through the implantables. So I'm actually going to say a little bit about some of this work because it may be relevant to some of the stuff you've seen, but we're also interested in the way that these signals that we measure from the patch, for example, change in the context of autonomic state changes and autonomic reactivity changes associated with, let's say, stress. And so, stress manifests as sort of changes in the brain that can then result to changes in peripheral physiology. Some of the peripheral physiological systems that are involved are typically the heart, the lungs, and other sweat markers. And so some of these things can, of course, be measured with non-invasive sensors. So we've done a lot of work on being able to use this wearable patch to detect changes in stress in populations such as, in this case, populations that have had prior myocardial infarction. So this is work where we collaborated with Emory University with a team that's been very excited about the intersection between neuro and cardiac, essentially. And so, as a person is at baseline state versus stressed, of course, these signals change, but they change in manners that may be sort of representative of the way that the person's physiology is responding to the stress. And so we've done some work in trying to differentiate the type of stressor, but again, I'm going to kind of move through this a little bit more quickly. So with this, I'm going to try to spend the remainder of the time talking about some of our work in joint health monitoring, moving completely to a different system, but you'll see some of the same kind of approaches are involved. So when I first started at Georgia Tech, I was very interested in joint sounds. And the reason was that, I thought that the measurement of these sounds could be a way for us to gain insight into what's going on inside of the knee, and specifically into the frictional rubbing of different surfaces inside the knee and how those may relate to injury or arthritis or other sorts of conditions. So I'm not sure if this is going to work, actually. Probably not. I'm actually going to stop sharing. I think I have to share in a certain way for this to work. Sorry, everybody. Give me 1 second. I forgot about this. I think Zoom has a particular characteristic. Yeah, share sound. Okay, now it should work. Can someone just jump in and say, are you able to hear this?
Yep, it's clear.
Okay, great. Perfect. Thank you. So this is the sound of a healthy knee. And you can see, this is basically the person is extending and flexing their knee, and we're measuring the sounds from the knee joint with these tiny accelerometers that are sort of broadband. And you can see that there's some, frictional acoustics there. You can kind of picture some of this maybe bone on sort of meniscus on ligament. There's rubbing of these different surfaces inside, but it seems fairly, controlled and steady. So these are the knee sounds from a person who's had an ACL tear. And in this case, with an ACL tear or anterior cruciate ligament tear, which is very common in sports like soccer, football, basketball, it's sort of a major knee injury. It takes 9 months or so to recover, if that. And with an ACL tear, you get laxity and instability in the knee. And with that, there's these loud kind of clicks and pops that occur when the person is basically flexing and extending their joint, and when things are sort of hitting each other that are maybe not supposed to hit each other. So I'm sorry, I should warn you guys. So the next couple slides, at least the next slide for sure, has some photos of cadaver limbs. So if that kind of thing is going to upset you, then just sort of turn away. And I'll tell you when we're done with that. So again, in this work, so similar to the cardiac vibrations work, very little had been done in the field of joint acoustics and in relating these acoustic patterns to specific injuries in particular. There had been some work done on arthritis and osteoarthritis in particular, but again, very limited. And no one had done anything with wearable measurement of these sounds where you could actually, say, take a brace that had accelerometers or microphones in it and measure these things longitudinally. So that was the major kind of innovation and breakthrough here. And what we had to do was we had to better understand specifically how do various injuries affect these sounds. And so to do that, we can't generate an injury in a human, obviously, and measure before and after. So we had to use cadaver limbs to do this. And with the cadaver limb, we basically measured the sounds coming from the limb as a human was actually, extending and flexing the limb with their hands. And then what we did was we would induce an injury, specifically a meniscus tear, and look before and after that injury at how the sounds changed. And with this, we were able to better understand, markers of these changes that were associated with that injury. I have a TEDx talk, by the way, that you guys can check out if you're interested, that presents this in a little bit more of like a storytelling and fun sort of way, where I make fun of the whole process. So feel free to look at that if you're interested. But here we're getting a little more into the engineering details here. So we had to do quite a bit of work on the embedded system side of things to make it work. These sounds, basically you have these 44 kilohertz bandwidth kind of signals with quite a bit of bit depth, 16 bits typically bit depth, that are being recorded 4 channels at the same time, together with bioimpedance measured at multiple frequencies, as well as inertial measurements on the knee. And so with that, it ends up being a little bit of a tricky kind of problem. My student, Caitlin Teague, who's since graduated, is now a research scientist at Northwestern Memorial Hospital. Actually, she did some amazing work on this to make it work. But anyway, with this, we did quite a bit of work and various studies. We did one study. Our initial work was in student athletes at Georgia Tech. And what we wanted to do was we wanted to look at the knee sounds after an injury, immediately after the injury, and then also after rehabilitation, basically surgery and multiple months of rehabilitation, to see if we could tell any differences in these sounds. And these are really noisy sounds, for lack of a better word, and they're kind of very difficult to analyze. So I had a student, Sinan Hersek. He's now, again, since graduated. He's at Google currently, but he did some amazing work together with a postdoc who's now at Accenture, um, named Maziar Baran-Poyan. But they did some work together where they kind of took these sounds, created KNN plots with the kind of windowed versions of these sounds, and then examined the way that these plots changed, uh, both for sort of an injured subject and then also injured subject after surgery. And then from there, they basically used something called graph community factor, essentially to find what the heterogeneity was in these sounds based on this sort of graph model. And they demonstrated that that heterogeneity increased with the injury, basically kind of saying what we heard in the ACL tear sound, where there's a little bit more irregularity and a little bit more kind of, I guess, for lack of a better word, sort of chaotic nature to the measurements, and that actually was found to be a significant difference for all of the subjects in the study. Since then, we've done quite a bit of work in juvenile arthritis as well as rheumatoid arthritis. So I'll present the adult results first. So this was some work that we did in collaboration with the University of Minnesota. Christy Richardson was a student who worked on this. She's now at Sandia Labs, actually. And we had deployed this system basically at the University of Minnesota and the medical school there, where we measured joint sound and bioimpedance recordings from patients with rheumatoid arthritis in this clinical trial that was going on as kind of surrogate measure, or a supplementary measure, I should say, of joint health and performance. And what we found was actually from the sounds together with the bioimpedance, which tells us about the edema locally in the joint, or swelling locally in the joint, we were able to reconstruct from the wearable signals alone the high versus low disease activity. And that was basically, disease activity normally has to be derived using the score called the DAS28 ESR, which includes both physical exam as well as blood tests, so erythrocyte sedimentation rate, blood test results, and through our measurements of the sounds, the joint angles, and the bioimpedance, we were able to accurately classify the people who had basically high versus low disease activity in joint. And this is exciting because this could mean that a person could take the brace with these sorts of measures home, and you would be able to know if they're having a flare-up, for example, if a certain medication was actually reducing the sort of effects of the flare-up, you might be able to detect that. And so there's a lot of exciting possibilities for longitudinal studies here. This was some work from Nick Bolas, who did some great stuff afterwards in sort of entrepreneurship, and then decided he wants to go back to med school. But anyway, he did some really cool stuff on being able to detect the stiffness of the Achilles tendon with some active sensing approaches. So specifically here, you can kind of think of this almost like a guitar string that's being plucked by a vibration motor. And the tighter the guitar string, the more that sort of the energy kind of travels easily along the string, in this case, the Achilles tendon. And so he was able to determine that actually you could get kind of the sort of burst patterns could be produced by these vibration motors, and you could detect the tension in the tendon based on sort of calf raises and other activities. And this is something now that we're extending also into use in kids with arthritis, actually, to determine if there's specific sort of, especially if there's tendon stiffening at the connection between the tendon and the bone. And there's some really interesting work we're doing there. And sort of last thing, I'll leave this as a teaser. You know, this is something that we're really excited in, and this is not just for athletes, but it could also be exciting for, you know, fake athletes like some of us maybe, who are older and who like participating in sports and always get injured because, you know, our body sucks at this point. But there's some cool stuff that could be done maybe with these technologies to be able to detect as early as possible the risk of an overuse related injury. And so this is something that we've sort of toyed with and are very excited about trying to find ways to implement these sorts of studies. It would involve a prospective study, so it's kind of complicated, but it could actually be a very exciting and highly impactful thing if you could tell somebody, let's say, days in advance or even hours in advance that, hey, your joint might be at risk of, patellar tendonitis. You might want to back off for today, or maybe you're doing great, but keep working at it. Today is a great day to have a big time workout. So these are some of the things that we're interested in the future as well with this joint health monitoring sort of technology. So with that, I'll kind of leave it. Of course, obviously, we have some great supporters and students and all that and collaborators, and kind of I'll leave it here. Hopefully, that's somewhat close to the half-hour time. I see that I probably went slightly over, but that's okay, hopefully. And I'd love to get questions and input. Oh, I see now there's some chat. So sorry, I didn't see that at all.
Yeah,
do you guys want me to first look at the chat, or will you read the chat, or what do you want me to do?
We can run back through the chat. Yeah, so just I guess in terms of protocol, we've got lots of time for questions and for discussion.
Awesome.
So let's run back through the chat, and I think what I'll do is invite folks who had put questions into chat just to jump into the conversation. So let me just scroll back through here. I think Cameron Hurd had the first question. Cameron, do you want to go ahead and follow up with Omer?
Hello.
Yeah,
hey.
Hi there. I was wondering when you were showing these sounds of, I think it was the knee. Yes, the knee. I was wondering how that sound differed based on demographics like age, like how that may sound for, say, a teenager versus someone that's maybe approaching, like, say, their 60s, something like that.
Yeah, there's a lot of differences across age. So we actually have a data set where I didn't talk about even some of our results in kids with juvenile arthritis, but we have measurements all the way down to, I think, kids who are 4 or 5 years old, all the way up to actually some of the people that were in the rheumatoid arthritis study, I think were maybe close to 90s. So we have a pretty widespread. The tough thing is that there's a lot of things to normalize for. So I guess to truly answer your question, nobody knows. Everybody knows there is an effect, but nobody knows how, to what degree age plays a role in shaping the sounds. I think that, and the reason for that is that many things are at play, like how much has the person been loading their joints? What's the person's weight? Have they had any prior injuries? Do they have any existing arthritis? Do they have other anatomical differences in their knee? There's so many things that affect the nature of these sounds that it's very difficult to do anything in terms of an absolute, let's say, diagnosis based on the acoustics. Although for kids, what I'm saying is actually not that true. So in kids with juvenile arthritis, we have actually had very good results in being able to detect the presence of arthritis in sort of a diagnostic manner. And the reason is that most kids, if they don't have arthritis, they actually don't have much in terms of sounds from the joint. So, you haven't really seen much wear and tear on the joint yet. The surfaces are pretty smooth, the friction is pretty low. And so if you have a kid who's, 8 years old, typically you won't have much in terms of joint sounds. You definitely won't have something as loud as, what you listen to even for the healthy subject. So for kids with arthritis, actually, it's pretty, there's a big difference. And we published a couple of papers on that. One very recently this last year in a clinical journal, Pediatric Rheumatology, that demonstrated actually very good results in detecting the presence of arthritis in kids in sort of age-matched population. Now, but your question about the effect of age, I don't think anybody knows that. I think it would require a very big data collection. It would be super interesting. I'd love that. One of my longer term kind of interests and passions with these joint sounds is to create such a data bank, that could then be used to address many of these questions about demographics and their effect. It would be a big process. Sorry for the long answer. It's just, very interesting question. Just not a straightforward answer, I guess.
Thank you. Thank you.
Right, thank you, Cameron. Next in chat order, Yossi Chut.
In chat, should I look at the chat?
No, sorry, that was that was the name of the next book.
Oh, sorry. Yeah, got it.
Yossi, yeah, do you want to jump in and ask your question? I guess not. And again, I think there was maybe a typo in that question, so I'm gonna.
Yeah, I don't actually understand the question, so
yeah, we'll pass it by for now, and we can loop back around.
Okay.
Rishi is
I'll
next.
jump on. Sorry, I didn't have the mic on. Can you hear me?
Yes, go ahead.
So does the sound change based on the grade of the tear? You know, you go from 1 to 5. 5 is
Oh, yeah. Again, I don't think we know that. I mean, I think that for a meniscus tear, it's really more based on, is there a tear or not? And then even with meniscectomy, it didn't make a big difference. I think this is one of the things where this sort of subtlety of again, it's a data collection that would require a major sort of set of resources that we haven't had a chance to be able to have that level data collection there.
Thank you.
It'd be super interesting, but nobody has that kind of data.
All right, so I think the next couple of questions are related. They're around the filtering of noise and ambient effects from the audio recordings that you're performing. So how do you deal with this, like a signal processing level of collecting that data in a way where you're focused on being able to hear the joint sounds and not everything else that's going on?
Yeah, this we've done a lot of work with, so this is a little bit easier to answer, I guess. In terms of the joint acoustics, so because of the fact that we use contact microphones, which is basically accelerometers that are directly adhered to the skin, we actually get very little of background noise coupling into these signals. And the reason for that is that you're basically picking up the vibrations of the skin directly. And by the time external noise gets to the point where it can couple into the skin, it's actually very attenuated. You have to pick it up in air. So if it were a typical microphone used, then actually there would be a lot of background noise. But with contact microphones, those are the types of solutions used, for example, by fighter pilots and helicopters to be able to avoid background noise. So it's very robust to that. But the kind of artifacts that do matter are things like cable noise, any sort of movement of clothing or vibrations on top of the sensor and that kind of stuff. We've done a lot of work on that sort of thing. We've done some work on using sort of data augmentation, synthetic noise generation. We've done that with the cardiac signals as well, where we kind of model the types of noise that can be present using either lab experiments or data collections. For example, for the cardiac signals, we had done a data collection where we actually measured acceleration waveforms on the subway here in Atlanta, and determined what types of vibrations are present there on other vehicles, also cars sort of driving around, to then form a sort of database that provides us the characteristics of the noise sources, which we could then scale and adjust to be able to synthetically add to our signals that were measured in cleaner environments, and then determine ways that we might be able to reduce those noises. So we've done a lot of work kind of combining both synthetically generated data, synthetically generated noise with real data, sort of real noise, in ways where we could sort of augment our data sets and work on the extraction of those signals. There's still a lot of work to be done there, but I think that we have a lot of sort of publications with our collaborators on that sort of topic. And it's a very important problem for any of these sort of wearables that you see out there. This is a challenge, right?
Okay, thanks. I think there were two follow-ups. Maybe Rishi Dakrapu, do you want to go ahead and ask your follow-up on that?
Yeah, am I audible?
Yes, go ahead.
Yeah, sure. Thank you. Doctor, I actually had a question. I think you clarified that you're using microphones that actually stick to the skin. So two questions essentially. First one is especially for the cardiovascular situation where people will be wearing them throughout the day in their day-to-day activities. In that particular case, how are you dealing with the noise in a way in which the battery consumption, those things are also reduced? Secondly, I was also wondering whatever algorithms you are using to sort of pick up the differences between various NUI as well as heart-related stuff. If we are using like a digital stethoscope, which is coupled with a typical smartphone, for example, can this solution actually be used from a mobile health perspective where it can be more like even people in remote areas can use it? I'm just thinking out loud. Thank you.
Great, thank you. Yeah, so there are some companies actually that are trying to build smartphone-based approaches to measuring the same kinds of signals that we measure with our patch. I think the major challenge is the fact that having good mechanical adhesion between the sensor and the skin is really important for the signal quality. Also, concurrent measurement of the electrical signal, the ECG, is really important to contextualize when the waveform is occurring. And so it's a little bit tricky, but that's definitely a way that people are trying to go. I think that from sort of my perspective, for the types of problems that really require this device, I think having a device that produces really high quality data is very important. And so there might be some applications where that makes a lot of sense. We've also worked on a watch-based approach where the person actually pushes the watch against their chest. We call that Seisma watch. That's an interesting approach for that as well, that may allow it to be more sort of mHealth friendly or mobile health friendly. As far as your first question, I think it was related to the sort of noise in everyday environments. I think that's kind of what I answered before, I guess, but I'm happy to go into it more if you had any other follow-ups.
No, I think thank you.
Awesome, thank you.
All right, so moving down the chat. All right, so a question from Jim and Inan about how you quantified stress levels for the stress work that you were doing.
It's a good question. How does anyone quantify stress levels, right? So that was actually a very interesting study. I had to gloss over it here, but there's a lot of literature on what we did there, basically, that I can send over if you're interested. But the main purpose of our work there was actually on intervention for reducing the physiological reactivity to stress in patients with PTSD in particular. We've now since expanded that to also patients with opioid use disorder during active withdrawal. But this was a close collaboration between my group and Dr. Bremner, who's a psychiatry and radiology double-boarded psychiatrist at Emory. And basically in that study, we had a multi-day study where there were different stressors that the person was exposed to, including traumatic stress, which is really the recount of their traumatic event for patients with PTSD, mental stressors like mental arithmetics, public speaking tasks, that kind of thing. And what we had actually several brain scans that occurred as well with the high resolution PET scanner that they have at Emory. So we're able to see the different activation of regions in the brain, as well as we had blood draws that were occurring regularly that allowed us to detect changes in various cytokine levels and other sort of stress biomarkers in the blood as well. And then while we were doing that, we had the wearable sensor signals that were being sort of recorded concurrently for the whole process. And the goal actually with that study was we were using a vagus nerve stimulation device from this company called GammaCore. Excuse me, the company's electrocore, the device is GammaCore. And basically there was a sham group and an active group, and we were comparing the responses in these participants. At the same time, it allowed us to have a really interesting way of collecting wearable sensor data in the context of various acute stressors, together with some really interesting gold standard information in the imaging and blood biomarker data.
Right, good. So there's a follow-up question about signal processing again for the chest patch. So Ryan Amadi, do you want to jump in and ask your question?
Yeah, sure. So in terms of the actual signals you get from the wearable chest sensors, might be on the order of a couple of microvolts or maybe a couple of millivolts. I don't know. What kinds of amplification and maybe low pass filter, band pass filter type circuits do you need downstream from the sensor in order to actually have sensor data that's actually usable?
I mean, there's clearly there's a lot of that, right? So there's a lot of sort of processing and amplification on the actual device. A lot of that stuff is commoditized at this point. So you have actually dedicated front end analog front ends from companies like Texas Instruments or Maxim that that allow you to actually measure these signals in a way where they're already amplified and somewhat pre-processed at least a little bit. And then we have a whole signal processing and machine learning pipeline that our lab has developed that includes things like signal quality checks for the various signals. That includes things like bandpass filtering, as you mentioned, but also a lot of times, noise reduction algorithms, which might, take different sort of flavors depending on the signal and the sort of problem set. So, we have a lot of this stuff that we've, I guess, developed over time. A lot of it's also fully, available in our papers and that kind of thing. So.
Okay, great, thank you. Let's see. So I think there are a couple of other questions that have come in since the talk finished. Maybe what we'll do is just open out the questions. So if folks just want to do a Zoom hand raise, I'll loop around to folks, and maybe while people are getting ready to do that, I might invite our center directors Deepak Kanistan and Nitish Chaudhary to ask any questions they might have.
I have a question for Omer.
Yep, go ahead.
First of all, it's very impressive and just amazing work.
Oh, thank you.
I'm happy I was able to be present. So, cuffless blood pressure is big deal these days. Maybe in the last decade, there are some papers relating heart sounds, especially S2, to blood pressure. Have you done any work on it? What are your thoughts?
Well, our lab has done a lot of work on cuffless blood pressure, so have many other labs. We were actually part of this UO1 that included Michigan State, University of Maryland, and Rochester, and also at the time Xerox PARC, and then turned into GE Research, focused on this problem. I would say it's a really, really hard problem. I mean, there's a lot of literature showing that there's some pretty good results. There's also a lot of literature, though, especially recently. For example, Microsoft Research put out this paper that included results with their Aurora data set that showed actually a very negative result for cuffless blood pressure estimation. And a lot of it's known physiological issues associated with the approaches that are out there. In terms of S2, I don't know about that particular issue. I mean, heart sounds, anything where you're using heart sound amplitude is challenging because for each person, the amplitude of S2 is very different with chest anatomy and all that kind of stuff. So maybe if you had a calibration, changes may have some value. I think it's just a very hard problem. I think that there's also companies have been pouring literally hundreds of millions to billions of dollars into this problem to try to address it. And there's some devices that have been FDA cleared, but then you talk to experts in the area and they're very, very, either they've never seen the device or they're very right, or they don't work. Yeah, exactly. Yeah. I mean, that's kind of the difficulty. So I think there's a lot that has to be done still in this space. There's a lot of interesting startups that are trying to do cool things in this area. I think that pretty radically different approaches than what's out there are needed to have a successful result in this. That's just my personal take on it. I mean, I hate to be sort of negative about it, but I think it is a really, really hard problem.
I agree. Thank you.
No, definitely. Thanks for the question. Thank you.
All right, and we've got Kurash next. Kurash, go ahead.
Can you hear me?
Yes.
Hello.
Yes.
So I have this question. So sometimes the structure of the knees are not normal. For example, the person suffers from genovarm, or they had, for example, rachitism when they were a child. So do you have any data that shows that you receive the same sound from this kind of bones and knees as normal people?
Sorry, can you repeat so in what kind of population compared to, sorry, say again?
For example, some people suffer from genovarm when the knees are structured like a vowel or X. They are not normal. or when they were a child, when the patient was child, they had rushitism, so their knees are structured differently. So do you have any data that this joints that they are not structured in a normal shape, do they have the same sound as the normal people or not?
No, we don't have any data on that. I mean, that sounds interesting. I have no idea. I have no idea what it would sound like. Even for normal knee anatomies, there's very little known about these things. Like there's a lot of work that's been done on it, but very focused on osteoarthritis. Not too much beyond that, honestly.
Okay, thank you.
All right, I don't see any other hands raised, so I'll maybe close it with a bit of a higher level question. So I think, Omer, in your talk, you presented quite a range of different studies. And I was wondering if you could comment for us a little bit on how you think about the validation process for the devices that you're developing. You're doing a lot of sort of benchtop to sort of deployment kind of work with different populations. And I think this is related to the question that Cameron had asked about how to think about sort of organizing in this process, this space, and how to think about processes to get things really from the lab out into the field and into the real world to benefit patients. So any comments you have on how you think about structuring the validation process, picking populations, how you target the experimental work that you're doing would, I think, be of great interest. So thank you.
Yeah, no, thanks. That's a great question. I mean, it's one of these things where I feel like for us, at least, the process has really been that we do as much work as we can in humans, right? So if there is a way that we can get to human studies faster, we try to do it. Sometimes that involves there's a little bit of a push and pull there where we have to develop the device, let's say, to the level that it has to be to get data in human participants that allows us to better understand what we're measuring so that we can then iterate and improve on the device and actually get to more meaningful studies. And it's difficult always to decide, at what level is the device kind of ready to go into, for example, clinical studies beyond just what we do sort of in the lab, what we do, in standard sort of healthy human subject data collections and that kind of thing. We have a lot of collaborators. That's one of the things. Part of my process is to always, from the start, have clinical physiological experts on the project that help us to make sure that we're not chasing a problem that doesn't matter, right? So that's been important from the start. I think what's always hard is a lot of these questions, for example, that were asked are very good ones. And what's hard, I guess, with our research, and you would probably share this, anyone would share this sort of thinking, is that we have to do so much bits and pieces research because of the way that funding works, that it's really difficult to kind of put together the puzzle pieces in a way where you really feel like you're making as much aggressive progress towards the goal as you could be if your vision were sort of funded by one kind of entity that could push some technological area forward, let's say, right? Like with the joint sounds thing, it's very interesting questions around prospective collections to be able to potentially detect the risk of injury, the concept of creating a large data set that includes people of different ages, different body types, to be able to start having better understanding of what affects the sounds, and how. I mean, a lot of these things are super interesting, but it's very difficult to kind of have a coherent stream of funding other than just sort of, this entity is interested in this aspect, this entity is interested in this aspect, and they're going to give you basically like 1/2 of a student to work on this, or 1/3 of a student to work on that. I mean, I would say, I don't know if that answers your question, but that's kind of, I guess, what I would think about it.
Good. Yeah, thank you. That's great. All right, so I think we'll leave it there for today. So thank you again, Omer, for the great talk and for answering the questions. Just remind everyone again, plug the next webinar, Santosh Kumar, coming up in about a month. So the link is in the chat if you'd like to grab that. Hopefully we'll see everyone again in September. So thank you very much, Omer, and everyone for joining. Thanks.
Thanks, everyone. Thanks, Ben. Thanks for having me for this. Thank you.